We're joined by Professor Michael Scott from University of Pennsylvania. We've just heard from Mirko Nakoti, an anesthetist and critical care physician from northeastern Italy. Michael, what were some of the big takeaways that you had from Mirko's description of what's happening on the ground with the COVID-19 virus and the response to that there in their region?
Really does focus your mind, doesn't it? He's talking about 500 patients needing critical care in his region of about 1 million people. He's talking that it's a public health problem because ultimately there's a 60% infection rate. So it's a numbers game, containment strategy, reduce those that get infected. And the other thing that's becoming apparent is not to move your patients around the hospital, to cohort them. And so I think the key thing here is we need a sort of statewide, county-wide strategy. We might need even dirty hospitals and clean hospitals. So it's vital that different healthcare systems are actually going to be talking to each other so that we can mount the correct response. Because what he's saying is once you've contaminated your health system, it's not just you can't treat COVID-19 patients, you can't treat women and children. And that is very concerning. The critical care strategy, he's saying that this is not a difficult disease, but you get overwhelmed quickly. So I think that's my take home, is that we need to work out how to contain this in separate COVID-19 critical care units. A strategy too, I think, for early intubation, and then to reduce contact of staff. They're a couple of weeks in now, and I think maintaining your staffing is key. And we need to limit our staffing exposure early on so that we can maintain the numbers of staff through the pandemic.
For Michael, from what you've heard that's happening here in the U.S., do you feel that that is some of the preparedness, what we're doing there, and we're moving in that direction here in the U.S.?
I'm unclear. We've got the numbers from Seattle and from New York now. I think different healthcare systems will be taking a different approach. I think we've been very lucky to have an insight from Italy. So our own healthcare system has really ramped up very quickly in the last 72 hours. So what do you think, Maurizio?
I think we are moving fast. If I have to speak locally, of our country, we have giant amount of resources, and when I heard the number of people we can put on a mechanical ventilator in this institution, my jaw literally dropped. However, I'm not entirely sure if the rest of the country is moving as fast. I suspect, talking to other people, their administrators and even clinicians are not really appreciating the severity of what's coming upon us, and they're late. They're barely realizing that there is a problem. I get it from the response and from the way they even the seriousness, the lack of seriousness with which they respond to me when I tell them, guys, you have to move. So that's my concern. There may be a delay, especially in in the smaller institutions and in the smaller hospitals. I agree with everything Mirko said about the community response, a response of public health, more important and more relevant, more crucial as our response, hospital-based response, and try to maintain patients alive. But without a community-based response, I think we're going to have lots of troubles. The main message for other hospitals would be get ready, get organized, think in terms of disaster management, disaster planning, be creative in your solutions, try to think of modes of practicing that are not really in our standards of care, but at this point, I don't think it matters anymore. We have to be creative, proactive, and extremely quick because we do not have time.
From what Mirko said in particular, I thought I was reasonably well informed about all of this, and I had read the papers that he referred to. But it seems as if we get this wrong or we're unlucky, as I think there have been in Bergamo, is it can be truly overwhelming. I think all of us in critical care who work in large urban centres or who have done have experienced mass casualties before, whether it's things like outbreaks of diseases or terrorist attacks, for example. But usually that feels overwhelming when we receive patients in the tens, 10, 20, 30 patients all at once. I've never experienced anything where we're dealing with patients in the hundreds. So if it, as he described, 500 patients needing critical care support in a relatively short order is potentially truly overwhelming. So we can't be over-prepared, and we will probably have to think right outside the box on this one.
Yeah, Maurizio.
Yeah, so it's a massive casualty, it's a massive disaster. But imagine that happening every single day. That's what it feels like over there. Imagine a bomb explode every single day, and every day needs a bigger bomb. So that's what they are experiencing over there. And again, this is the message that has to come through, because I'm afraid that most clinicians and administrators are thinking this is just another bad influenza season. I heard this so many times, I'm getting nauseous, honestly.
Yeah.
This is not.
Well,
if this ends up being some degree of catastrophizing and we've over-prepared, then praise the Lord. That's a good problem, isn't it? Yeah.
I told them I'm happy to give up my paycheck and go make pizza if I'm wrong.
Yeah.
Yes, I hope so. I like making pizza.
Yeah. Well, hopefully some of the things that we're starting to put in place, I know our local government here in Kentucky, we've closed schools, we've stopped social gatherings over 200 people. We're, closing nursing homes. I mean, we're already starting the social distancing, or what I call social complete disruption, to hopefully, stop that massive, contamination and spread of the virus. So hopefully that's going to help.
Can I add a couple of things? One thing, this patient seems to respond very well to the prone position when they're sicker. There's a minority of patients that require extracorporeal support. There's a lot of attention here in this country on ECMO, extracorporeal circulation for respiratory failure, or extracorporeal lung support. It is, I think, focusing on that is a false problem, because the majority of these patients do not need that. They can be managed with conventional, very simple management. And if they're really sick, if you put the patient with their belly down, they seem to improve dramatically. So, which is a very, very good thing, because we wouldn't be able to support with extracorporeal so many patients. There's an aspect that is very peculiar that puts Italy and other European countries at an advantage, and is harder here because of a lack of a device. They have a lot of patients who they are able to manage without a breathing tube, using a device that allows to give CPAP, which is continuous positive airway pressure, by placing the patient in a helmet. It's a pressurized helmet, expands your lungs. And what you do is you can use the device by giving flow, and you can place a filter at the exhaust outlet, so that where the gas comes out.
Yeah.
This way, patients receive positive pressure without having to be intubated. This can be managed on the floor. As of this morning, my old hospital had 100 patients on this device on the floors. Imagine if they didn't have this, they would be intubated. The problem we have in the United States is that this device is not available, and so the choice is intubate these patients early, as soon as they fail conventional oxygen therapy, or use non-invasive ventilation devices using masks or other types of devices that are at risk of spreading the virus even more, because they aerosolize gas. So I wish we had that helmet. We're trying to actually do something about it. But as of now, we cannot use exactly the same system that they're using, because it's not approved and is not sold in the United States. I keep emphasizing.
That's an interesting challenge, Maurizio. How could they accelerate that?
Exactly.
Because I mean, we're very.
And again, if a fraction of patients can survive and not be intubated, it is a massive advantage, because if you have to intubate 150 patients versus 50 patients, it's a big difference. I would recommend people to think creatively and try to use something similar if they can.
Gentlemen, I can't thank you enough for taking the time to talk with us on Top Med Talk about the COVID-19 epidemic and now pandemic here and across the globe. I hope that we can chat with you again in the days and weeks to come to update on what's happening there in your area. Michael, I know that we had talked about a couple different resources that will be available or that are available for providers here in the U.S. And around the world to use to help prepare themselves. Can you tell our listeners what some of those may be and what you have used to develop your protocols?
I think you've just got to go online and have a look. There's some useful groups developed on Facebook and Twitter. Obviously, the CDC websites and the Society of Critical Care Medicine in the US. We've got the Intensive Care Society and Royal College combined documents coming out of the UK, which Monty can talk about. And they're all very useful. I think what we hopefully do is put the links of these on the Top Med Talk Twitter site, if that's all right.
Yeah, and I think this is developing so quickly. We, the Top Med Talk team, as long as we can continue to do it, are going to engage in as many conversations between clinicians as possible. So anyone listening, keep it coming. It's important to talk.
Yeah, absolutely. I mean, what we heard from Mirko today is invaluable to how we approach this in the coming days, weeks, and months. So again, thank you guys for taking your time out. Thank you. And if you want to continue to join the conversation as we go forward, we definitely are going to be creating more content that is going to be available at topmedtalk.com, on our social media sites, Twitter, Facebook, LinkedIn. And we are going to be opening up some Q&A through slido.com. We'll let you know on our social media feeds how you can connect with us and start asking questions. And if you have a particular story that you want to share, please don't hesitate to reach out to us through our website, topmedtalk.com. So Monty, it's hard being apart with you in the UK and me here, but we're going to keep it going. Thank you guys so much.
Thanks, everyone. Be
Cheers.
safe.
Thank you. Great. Thank you so much. Thank you immensely.